Hello everyone, and thank you for joining my lecture that will cover Chapter 14, The Heart in the Human Body in Health and Disease textbook by Patton and Thibodeau. The goal of this lecture will be to discuss the location of the heart as well as the functional anatomy of the heart. We will also discuss heart sounds. We will trace the flow of blood through the heart. We'll talk about the vasculature that supplies the heart muscle, as well as the cardiac cycle and the electrical activity of the heart. We will finish up by discussing cardiac output and heart failure. I know we have spent a lot of time discussing how function follows structure or form, and I was doing some reading and I found that the whale is the animal that has the largest heart, and that makes sense, right? Because the whale is a really large animal. Something else that's really interesting and illustrates this point is the giraffe. The giraffe has a lopsided heart. The left side is bigger than the right side, and that is because the left ventricle is responsible for pumping blood all the way up the giraffe's neck to its heart. So again, a good example of how function follows structure. We're going to jump into this lecture and begin with talking about the location, size, and position of the heart. So if you look at this image here, you can see that the heart is kind of a triangular shaped organ, and it's located in the space between the lungs, which is called the mediastinum. About 2/3 of the heart are to the left of the midline of our body, and the remaining 1/3 to the right of the midline. If you take your hand and you make it into a fist, this is about the shape and size of your heart. Now, when we're listening to someone's heart, we listen at the apex of the heart. And the apex is the bottommost part of the heart that you can see in this image that is resting along the diaphragm. And we refer to that heartbeat as the apical heartbeat. Now, this is also good positioning for the heart because it is kind of sandwiched between the sternum, which lives in front of the heart, and the spinal column, which lives behind the heart. And this is what makes CPR possible, or when we press down on the sternum, we get those compressions of the heart. Do any of you remember what the normal heart rate is? If you thought or said between 80 and 100 beats per minute, you would be correct. So we're going to take a couple seconds and we're going to practice checking our resting pulse. So if you see this image here, if you want to mimic this and put your 2 fingers along the side of your neck, just underneath your jawbone there, you should be able to find your pulse. So I'm going to give you a couple seconds to find that. All right, now I'm going to give you 6 seconds, and when I say go, I want you to count the pulses, and then when I say stop, we're going to add a 0 to that, and that will be our resting pulse rate. All right, and go. And stop. All right, whatever number you got, I got 8. So you would add a 0 to this, that would be 80 for me. And then you can determine, is your resting pulse above the normal rate or below the normal rate? All right. All right, let's continue this lecture by discussing the functional anatomy of the heart. So if we look at the heart, we see that there are some chambers. If you look in this image, this is a transected view of the heart, and we can see that there are some cavities inside the heart. And there are 2 upper cavities or chambers and 2 lower cavities or chambers. The upper 2 cavities are referred to as atria or atrium if we're talking about just one, a right and left atrium. The lower 2 chambers are referred to as ventricles. We have a left and a right ventricle. So why would you expect that the atria are often referred to as receiving chambers, while the ventricles are often referred to as discharge chambers? If you thought or said that the atria receive blood and the ventricles discharge or pump blood to other areas like the lungs or the body, then you would be absolutely right. When we're talking about the atria, blood enters the heart on the right side in that top right atrium from the superior and inferior vena cava, and then it goes into the left atrium when it comes back from the lungs, and so the left atrium also receives blood. So atria are referred to as the receiving chambers. Like I said, the 2 lower chambers are called ventricles, and their job, and you can see if you look in this image how the walls surrounding the ventricles are a lot thicker because they have a really hard job to do, especially that left side of the heart. Left side ventricle has the responsibility of pumping blood to the entire rest of the body. And we will talk about in detail the flow of blood through the heart coming up here in a bit. Now here's an image of a real human heart, and you can see those ventricles and atria here. The wall of the heart is composed of muscle, and we talked about cardiac muscle previously. We referred to that as the myocardium, and the heart on the inside is lined with a very smooth lining, a lot similar to the lining that lines our vessels. And this is important to remember because if you think back to the lecture on blood, we talked about when a vessel becomes injured, that inflammation that occurs causes that lining to become rough, and that is what encourages platelets to start sticking to that area where hemostasis needs to be achieved, right? So the same can happen with the inner lining of the heart or the endocardium. If it becomes inflamed, which we refer to as endocarditis, those areas of inflammation can become roughened, and that is going to encourage platelets to stick there, which could potentially lead to a clot or a thrombus, as we've talked about before. And if that thrombus breaks loose, it can become an embolus, and it can go through the vascular system until it gets to a point where it gets stuck and it's blocking the flow of blood, which can cause ischemia. All right, so we already did our resting heart rate. So I'm going to encourage you for 30 seconds to just get up out of your chair or off your bed or the floor or wherever you may be at, and go ahead and just march in place or do some jumping jacks. But I'm going to give you about 30 seconds to get your heart rate up. All right, are you ready? 30 seconds starts now. Got about 15 seconds to go. Keep moving, stepping in place, jogging, doing some jumping jacks, some push-ups, whatever you would like to do. About 5 more seconds. Just keep moving. All right, and you can stop. All All right, so you should have your heart rate up a little bit. We are going to check it again. Remember that normal heart rate is between 80 and 100 beats per minute. So let's find our carotid pulse. And you can begin counting now. And stop. All right, we're going to add our 0 to that. See what your pulse rate is. Now, is it higher or lower than your resting rate? It should be higher, right? If we did it right and we were moving in place or doing some jumping jacks or something, it should be higher than your resting rate. So what's happening in the body? Why did our heart rate go up, do you think? Is this an example of a negative feedback loop or a positive feedback loop? So let's talk just a little bit briefly. We've already discussed this in previous lectures, but what is happening in the body? We are using up oxygen. Our cells are using up oxygen, all right? So if we were up and moving correctly and we got our heart rate up, then our respiration should increase as well, right? This is going to increase the amount of oxygen that is in our blood, and our heart is going to start beating a little bit faster so that it can deliver more oxygen because we have started to deplete that supply, right? That's pretty awesome how the body works. Remember way back to our lecture when we talked about tissues and membranes? We said that the heart is covered with something called the pericardium. And these are serous membranes, right? And there's two types. There's visceral and there's parietal, right? And we said that visceral membranes cover the organ. So we can think of this like the skin on a fruit or a vegetable as our visceral pericardium or epicardium, we call it. And that outer layer or kind of like this loose fitting sac that covers the heart is referred to as a parietal pericardium. And in between those two is a little bit of space, and there's going to be some fluid to reduce friction, but these membranes are very smooth, and that allows for the heart to beat within that pericardial sac. Now, sometimes a condition can occur called pericarditis, and this can be a result of trauma or viral or bacterial infections, and there's various other factors that could contribute to pericarditis. However, this can become very dangerous and cause something called a cardiac tamponade. As the inflammation progresses, fluid can accumulate, or blood can accumulate in that space between the epicardium and the parietal pericardium, and this is going to cause the heart to be compressed because there's fluid in that sac and there's nowhere for it to go. So it is going to start pressing back onto the heart, and that is going to cause a tamponade, and the heart is not going to be able to work as efficiently. Okay, so now we're going to take a look at the different valves that are in the heart. And there are 4 main valves that we're going to talk about. And if you look at the top 2 pictures in this image, I have numbered them in green 1 through 4. So let's talk about 1 and 2 first, and then we'll talk about 3 and 4. So valves 1 and 2 are referred to as the atrioventricular valves. This makes sense because they connect the atrium with the ventricle. Now there's a left and a right atrioventricular valve. They also have other names. The right atrioventricular valve is also referred to as the tricuspid valve. I think of that as try right. Always try to do the right thing. If you can remember that, you can remember the tricuspid valve is on the right. The bicuspid valve is on the left. That's our number 2. It is also referred to as the mitral valve. Okay, so bicuspid, mitral valve, and left atrioventricular valve are all the same animal. Now you'll notice that these valves have these little white things attached to them. These are referred to as leaflets, and the tricuspid valve, tri meaning 3, has 3 leaflets, and the bicuspid valve on that left side, bi meaning 2, has 2 leaflets. And attached to these little leaflets are little strings of tissue. Have you ever heard of heartstrings? Well, that would be these guys. These are referred to as the chordae tendineae. And the chordae tendineae are the strings that are responsible for pulling that valve open and then relaxing to letting those leaflets close. So we've discussed the right and left atrioventricular valves. Now let's move over to the next image and talk about valves 3 and 4. Valves 3 and 4 are referred to as the semilunar valves, and the semilunar valves connect the ventricles with a major vessel. All right, now the pulmonary semilunar valve connects the ventricle with the pulmonary artery. And the aortic semilunar valve, which is number 3, number 3 is the aortic semilunar valve, connects the left ventricle with the aorta, and blood. This is the pathway for blood to get pumped through the rest of the body. Number 4, the pulmonary semilunar valve connects the right ventricle with the pulmonary arteries, and this is the pathway where blood gets pumped to the lungs, and then it's going to return back into that left atrium. So these semilunar valves, if you look at the bottom images, you can see that when the atrioventricular valves are open and blood is moving from the atria into the ventricles, the semilunar valves are closed. And when the atrioventricular valves are closed, this is when those semilunar valves are open and blood is moving from the ventricles either into the lungs or to the rest of the body. Well, we pretty much covered the information on this slide regarding the heart valves, but I do want to point out 2 terms that are important for us to know. And the first one is the contraction of the heart. We refer to that as systole, and the relaxation of the heart, we refer to that as diastole. So now we're going to talk about valve disorders, and I found this image and I thought it provided a very good visual for us regarding what a normal valve looks like and functions like, and what a severely stenosed valve could look like. And it gives these little pictures of hoses down below, and I think this helps to make sense when we have a normal functioning heart valve. It's very open and the flow of blood is very easy and it's not impeded. But as that valve starts to become hardened or stiff or stenotic, then you can see from mild to moderate to severe how that opening is significantly decreased, which is going to cause a myriad of other complications throughout the heart as well as systemically. So when we have an incompetent valve, this allows leakage to occur, and what can happen is some of that blood that's supposed to stay in the ventricle, let's say, is going to get pushed back up into the atria where it came from. It's also going to reduce normal flow if we have some sort of stenotic valve or hardened valve. There are several reasons why this might occur. One reason is from a streptococcal infection called rheumatic fever. And rheumatic fever can lead to, if it's not treated or not treated correctly or quickly enough, can cause rheumatic heart disease. Now, streptococcal infections have a history of attacking connective tissues like the heart, joints, skin, and brain. In regards to rheumatic heart disease, the heart muscle becomes damaged, resulting in this inflammatory response to the strep infection. And then lastly, on our list of valve disorders is mitral valve prolapse. Remember, the mitral valve is the valve that is on the left. It's the left atrioventricular valve. And incompetence of this valve is going to cause the edges to, if it's prolapsed, the edges, those little leaflets, are going to extend back into the atrium when the ventricle contracts. So there's going to be a regression of that valve is going to actually be kind of pushed inside out and backwards and up into the atria itself. Here we're looking at an image that compares a normal mitral valve to a stenosed mitral valve, and you can see that the portion of the image on the left is very open. The valve looks a lot bigger, and then the one on the right, the stenotic valve, is very narrowed down and probably very stiff and highly immovable. Here we can see an image of what a normal mitral valve looks like and what a prolapsed mitral valve looks like. So you can see the normal one and then the one on the right, the prolapsed valve. As that ventricle is contracting, that pressure is pushing that prolapsed valve back up into the atria. That's also going to allow blood from the ventricle to flow back up into the atrium, which we don't want. When we do have valves that are stenotic or prolapsed, we can oftentimes replace them surgically, and there are different types. There are artificial ones, and there are also ones that are made of different animal tissues, like tissues from cows and tissues from pigs. There are two sounds that the heart makes that are clearly audible, and we have named these lub and dub. And these sounds come from the valves closing. So the lub sound comes from the closure of the tricuspid and the mitral valves, or the atrioventricular valves that we spoke of earlier in the lecture. So these valves are going to close so that when the ventricles contract, blood does not rush back into the atria. The lub sound is of longer duration and lower pitch than the second sound, which is dub. The sound dub comes from those semilunar valves closing, and this is going to allow the tricuspid valves to open while the atria do their contracting. Sometimes if we have one of those stenotic valves or prolapsed valves, we're going to hear an additional sound in there, and that is called a heart murmur. And the heart murmur is going to sound like a little swishing sound that comes just before the lub or just before the dub sound. Now we're going to talk about the flow of blood through the heart, and it's quite a complicated process. So we're going to look at this image while I kind of walk you through, and then we will look at the words and we'll hear it several times, explained in several different ways. So hopefully one of the ways will help it stick. So this flow of blood through the heart is important for us to know and will probably be tested on it. So we're going to start by talking about how the blood gets back to the heart from the rest of the body. At this point, a lot of the oxygen has been used up that the red blood cells are carrying, and that is represented by this blue color that you see here. So the blue color means deoxygenated, and the red color is going to represent oxygenated blood. So we're going to start on the left side, your left side. It would be the heart's right side with the superior and inferior vena cava. Now the superior and inferior vena cava are the largest veins in the body, and they're responsible for draining all of that used blood back into the right atrium of the heart. So superior vena cava and inferior vena cava are going to drain into the right upper chamber that we refer to as the right atrium or the tricuspid valve, right? So blood's going to enter into the right atrium. The tricuspid valve is going to open, and the right atrium is going to contract and push that blood down into the right ventricle. Now, the right ventricle is going to contract so that the AV valves will close. The semilunar valves are going to open, and blood is going to be pumped through the pulmonary semilunar valve, through the pulmonary arteries, which is only one of two times when we have an artery carrying unoxygenated blood. We can't define an artery by carrying one type of blood or the other. Remember, an artery is defined by a vessel that moves blood away from the heart, away. So here, that follows the rule. Blood is going to move through the pulmonary arteries to the lungs, and it is going to pick up oxygen there and dump off carbon dioxide. It's going to return to the left atrium through the pulmonary veins. Veins bring blood back to the heart. Once it gets into the left atrium is going to give a squeeze. The mitral or bicuspid valve will open and blood will flow into the left ventricle. At that point, the left ventricle is going to give a squeeze. The AV valves will close. The semilunar valves will open, and that's going to allow that left ventricle to push blood up through the semilunar aortic valve into the aorta and to the rest of the body. Now, there's two different types of circulation we talk about. One is pulmonary circulation, and that is from the right ventricle to the left atrium. All right, the flow of blood from the right ventricle to the lungs back to the left atrium. This is the shaded blue area. Okay, then systemic circulation is the flow of blood from the left ventricle. Remember, this is the red shaded area, from the left ventricle throughout the body and then back to the right atrium. So make sure you know the difference between those two. So it's easy to think of the heart like a pump, and we have the right atrium and ventricle as one side and the left atrium and ventricle as the other side. So the heart is basically a pump that's moving blood to the lungs to get oxygenated and then out to the rest of the body. When we talk about the contractions of the heart, the two atria will contract simultaneously, and while they're relaxed, the two ventricles are going to contract simultaneously. So in a subsequent lecture, we'll talk more about circulation and the peripheral vascular system, but I like this image because it gives a good overview of the flow of blood through the entire cardiovascular system. So again, we're going to start on the right side of the heart, and that is the blue area, the blue half of the heart. And we have inferior and superior vena cava bringing blood back into the right atrium. It gets pushed into the right ventricle. It goes up through the pulmonary arteries and to the lungs to pick up oxygen and drop off carbon dioxide. Now we have red blood returning through the pulmonary veins into that left atrium, moving through to the left ventricle and being pumped out through the aorta to the rest of the body via the arteries, the arterioles, and then the capillaries. And the capillary beds are where arteries and veins essentially intermingle with each other. And then we have the venules and the veins that carry that blood back to the heart. But here you can see that blue area representing the pulmonary circulation, and this yellow area representing systemic circulation. Pulmonary, remember, that circulation is going to do with the lungs. Where is the blood right before it goes to the lungs, and where does the blood end up right after it gets back from the lungs? Systemic circulation, we're talking about where is the blood in the heart right before it goes out to the rest of the body, and where does that blood come back into the heart? Okay, I hope that helps. One more time to just review the sequence of blood flow. You probably have it memorized by now. So quickly, one more time. Venous blood, that deoxygenated blood, is going to enter the right atrium. The tricuspid valve will open as the atrium gives a squeeze, which will allow the blood to move into the right ventricle. From the right ventricle, the blood is going to move through the pulmonary semilunar valve into the pulmonary arteries and to the lungs to pick up oxygen and drop off those waste gases of carbon dioxide. Once the blood is oxygenated, it's going to be returned to the heart via the pulmonary veins into the left atrium of the heart. The left atrium is going to give a squeeze and blood is going to pass through the bicuspid or mitral valve into the left ventricle. The ventricle is going to then contract and the aortic semilunar valve will open and blood will move from the left ventricle into the aorta and out to the rest of the body, and it will once again return via the superior and inferior vena cava to that right atrium, and the whole cycle will start over again. In order for the heart to do what it needs to do, it has to have an adequate supply of oxygen, right? So the way that it gets an adequate supply of oxygen is through the coronary circulation. And coronary circulation begins at the aorta. The first two branches of arteries off from the aorta are the right and left coronary arteries, and those branch into smaller arteries, and they all serve the purpose of supplying the heart muscle with the oxygen that it needs. On the reverse side, various veins come together to form the coronary sinus, and the coronary sinus opens up into that right atrium where the heart receives the deoxygenated blood, also from the inferior and superior vena cava. So if any point along this pathway there's a blockage by a clot or something like that, that can lead to a heart attack. The medical term for a heart attack is a myocardial infarction. Coronary artery disease is a leading cause of death in the United States, and one person dies every 37 seconds from some sort of coronary heart disease, and we're going to talk about a few different situations. Approximately 18 million adults that are over the age of 20 have coronary artery disease, which is about 6.7% of all of those over the age of 20, which costs the healthcare system about $220 billion each year. And something that I found to be really frightening was out of the 805,000 individuals that have heart attacks each year, 1 in 5 of those individuals has something called a silent heart attack. That means the person never knows that they had a heart attack, but their heart sustains damage nonetheless. So some different types of coronary heart disease. The first one is coronary thrombosis or embolism. Remember, this has to do with some sort of clot, either a stationary clot, which we refer to as a thrombus, or a moving clot, which we refer to as an embolus. And these clots can block the flow of blood to the heart muscle, and that causes those cells to start to die, and that is what leads to a heart attack. Another type of coronary heart disease is called atherosclerosis. And atherosclerosis and arteriosclerosis are two common terms that you'll hear associated with hardening of the arteries. And this is basically an accumulation of fat or fatty plaque on the wall of the vessel. And over time, this can build up kind of like, I'll go back to the example of plumbing in your house, how over time some gunk can build up in there and it can impede the flow of water or block it altogether. So this is a similar situation here. And then at that point, when the blockage is too severe, there's a couple things that we can do. One is called an endarterectomy, where we go in and we actually open up the vessel and clean it out and sew it back up. Or sometimes they can put in a stent, and that will alleviate the symptoms. And something else we can do is a artery bypass, where we use some sort of synthetic graft or a graft from the patient, like a saphenous vein, for example, and we can bypass above and below that area that is blocked. And then another situation that can occur is angina pectoris, which is due to a partial blockage of some sort. There is chest pain that occurs with increased activity, but abates when the activity stops, and the symptoms will subside. One form of treatment for blocked coronary arteries is to perform a coronary artery bypass. And you may have heard of the acronym CABG, which stands for coronary artery bypass graft. And what we will do is we will harvest a vessel from the patient. It could be a saphenous vein. It could be an internal mammary artery, and this vein or artery is used to bypass those blockages and restore blood flow to the heart muscle. The cardiac cycle is the amount of time that it takes for both the atria and the ventricles to contract and relax. And that takes a little less than 1 second, or approximately 0.8 seconds for a complete cardiac cycle. And in approximately 1 minute, the heart can pump 5 liters of blood. And that is approximately 2,000 gallons per day. For those of you that love math, I want you to tell me how many cups that is. So now we're going to move on and talk about the conduction system of the heart. Now, while the heart cells can beat by themselves, there needs to be some sort of coordination among them. And so the coordination is conducted by electrical signals that are sent to the heart. So that's what we're going to talk about next, and some important terms, anatomy terms that we need to be familiar with. The first one is the SA node, or the sinoatrial node, and that is also referred to as the pacemaker of the heart. It's located in the wall of the right atrium, and we're going to look at some pictures here in a second, near the opening of the superior vena cava. The atrioventricular node, or AV node, is located in the right atrium as well, but it's more up along the lower part of that septum that separates the two chambers. Next is the AV bundle, or it is often referred to as the bundle of His, which is located in the septum, or that separating, that muscle that separates the two ventricles. And then lastly is the Purkinje fibers, and the Purkinje fibers kind of spread out and down and along the walls of the ventricles. So all of these structures associated with that electrical conduction pathway. So here's an image depicting the conduction system of the heart, and where we are going to start is right here at the SA node, right? We said that that is the natural pacemaker of the heart, and you can see that it's located right here up by the superior vena cava. And so that's where our electrical impulses are going to start. And that electrical impulse is going to travel around this right atrium and across to the left atrium. You see that there? This signal is also going to travel down to the atrioventricular node. That's our AV node right there. We said it's located closer to the septum between the two atria. All right, from there, our signal is going to continue down the septum between the ventricles, and that is called the bundle of His. Right down here through the septum, where that arrow is, the bundle of His. All right, and as that signal travels down here, we refer to these little fibers that kind of come around and hug the outside walls of the ventricles as the Purkinje fibers, and they kind of branch out. You can see how they're branching out there. This is what is going to stimulate the atria and the ventricles to do their contracting when they need to, if everything is working properly. I thought it might be a good idea to just review the mechanism of a nerve impulse. Remember, the electrical conduction system of the heart is through nerves, right? So remember, when we're talking about the polarization and the depolarization of the neuron, do you remember that? First, we're just going to say that the neuron's membrane is at rest, right? It's at rest. It's slightly positive on the outside because there's a lot of sodium gathering around the outside of that membrane. Remember how we talked about that? At this point, a signal hasn't arrived yet, okay? When the signal arrives, that is going to stimulate those sodium channels to open up, and sodium is going to rush into the neuron, and that is what we call depolarization, right? Now the inside is more positive than the outside because we have all of those NAs, all of those sodium atoms inside the neuron now with all of their little positive charges, right? So now the inside's more positive than the outside, and that is what we refer to as depolarization. This causes a chain reaction all the way down the line. Remember, the cardiac tissue is just a muscle, like we've discussed several times about how nerves innervate these muscles. So you can think of it as depolarization is like the wind up, right? It's like if you think about a pitcher that's getting ready to throw the ball, depolarization is the beginning of that wind up, right? Because as soon as sodium rushes in, those sodium pumps are going to go to work pumping that sodium back out of the cell, right? So it's the wind up. And then the relaxation phase comes during the repolarization. So one of the ways that we can take a look at the heart's conduction system is by doing an electrocardiography, right? Or an ECG, sometimes also abbreviated as EKG. So these tiny electrical impulses that are traveling along the nerves through the heart muscle can be recorded, and this recording results in these visible tracings that we can look at to see if the heart conduction system is functioning properly or if there's something abnormal going on that might need to be further looked at or treated. Again, I'm using my baseball analogy where we're thinking of depolarization as the wind up. Now, as surgical techs, we do not read EKGs, okay? So we don't have to, determine if there's arrhythmias or if it's a normal, conduction system. We don't have to determine that, but it is important that we just kind of take a brief look at the 3 different waves of the EKG. And that first one is the P wave. And the P wave is associated with the depolarization. All right, so this depolarization of the conduction process is going to trigger the contraction of the atria. Again, it's the wind up before the contraction. The QRS complex is associated with the depolarization or contraction of the ventricles. So when you see P wave, think contraction of atria. When you see QRS, think contraction of ventricles. When you see T wave, think of repolarization of ventricles. Remember, repolarization is the relaxation phase, right? The ventricles are relaxing. So again, we don't need to know any more than this about EKGs. It is not something that is required for us to perform. Here is a little chart that I created that I thought might be a helpful visual for us when we're talking about P wave, the QRS, and the T wave. Again, when you think P wave, think atrial contraction or depolarization. Remember, that's the wind up. When you see QRS complex, think of ventricles contracting or the depolarization of the ventricles. And then the T wave is the relaxation of the ventricles or the repolarization of the ventricles. Those are the things that we need to know. All right, let's review some of the different cardiac dysrhythmias. First, we're going to talk about heart block. Now, just to get back to our medical terminology, dysrhythmia means abnormal rhythm of the heart or abnormality of heart rhythm, and heart block has to do with a blockage somewhere in that conduction pathway. When an individual has complete heart block, that means that the atrioventricular node, remember the one that's close to that septum of the atria, there's a block there. So there's going to be a dissociation between the P wave and the QRS complex, and can be treated by implanting a pacemaker. And the first pacemaker was implanted in 1958. Some other rhythms, and this just goes with our medical terminology, bradycardia and tachycardia. So brady means it's going to be a slower than normal rate, and tachy means that it's going to be a faster than normal rate. We can also have something called a sinus dysrhythmia, and this is a variation in the heart rate due to the breathing cycle. Remember, our thoracic cavity is a closed system, and therefore there are pressure changes within that cavity when we inhale and exhale. Something else could be premature contraction or extrasystole, which is when a contraction occurs sooner than expected. And lastly, fibrillation. Fibrillation is more like a quivering of one of the chambers, one or more of the chambers, instead of a regular contraction. So we say that the cardiac muscle fibers are out of step and they're not producing that full contraction that the heart needs. So more of a quivering or a vibrating type effect. Here we're looking at some EKG strips of dysrhythmias. You will not need to know this on a test. You will not be required to identify these on a certification exam either. This is just for your information. The top one is complete heart block, and then we have our bradycardia and tachycardia. You can see how bradycardia, the contractions are farther apart, where tachycardia, they're a lot closer together. And then we have our sinus dysrhythmia and our premature ventricular contractions. And then lastly, two different types of fibrillation, atrial and ventricular. When we're trying to treat an abnormal heart rhythm, there's a couple things that we can do. First, if somebody is in cardiac arrest, let's say, automatic external defibrillators have become pretty commonplace in hotels or restaurants or airports, wherever you might see these on the wall. And these are used in a situation where someone is in cardiac arrest, and it will actually assess and detect if there's an abnormal heart rhythm, and if so, will advise a shock to be delivered. So early defibrillation is the key in the case of a myocardial infarction. There are also implantable defibrillators, or ICDs, that can be implanted similar to like how a pacemaker would be implanted, and they can perform a similar function as the AED. And then atrial ablation is a procedure that can be performed in like a cardiac cath lab. And basically what they're doing is using thermal means, some sort of cautery. Sometimes they also use cryoablation, and they either freeze or burn some of the fibers, and this helps to eliminate some of those overactive electrical signals that could be causing the fibrillation. Two other terms that are good to be familiar with are stroke volume and cardiac output. Stroke volume is the volume of blood ejected from one ventricle with each beat. And then the cardiac output is the amount of blood that one ventricle can pump in each minute, right? We said about 5 liters per minute when we're at rest. So stroke volume is just one beat from the ventricle. Cardiac output is 1 minute worth of beats from the ventricle. So here we're measuring volume of blood, how much is being pumped out within a certain amount of time. Remember when we were talking about the nervous system, we talked about the autonomic nervous system, and there are two divisions of the autonomic nervous system, the sympathetic and the parasympathetic divisions, and this is what controls our heart rate. Remember we talked about neurotransmitters and how they get involved, and here norepinephrine is the neurotransmitter that is responsible for helping the sympathetic division speed up our heart rate. And then the parasympathetic portion of the autonomic nervous system is responsible for slowing down our heart rates, right? Parasympathetic, we're kind of like rest and digest, right? So it's going to slow things down through the use of the release of acetylcholine. And then we also talked about how when we increase our activity, that is going to use up the oxygen stores more quickly. It's going to put off the waste gases, and so that's going to cause our heart rate to rise and our respirations to increase to try to restore that the normal level of gases in the blood or achieve homeostasis. Similarly, a drop in blood pressure can lead to an increased heart rate to restore that normal flow, right? The body's tissues still needs just as much oxygen, but if we don't have as much blood in the system, it's going to have to work harder to get that oxygen to the tissues. Okay, let's talk a little bit about heart failure. Two different types of heart failure, right heart failure and left heart failure. We're going to talk about left heart failure first. This is also referred to as congestive heart failure, and it can be caused by various disorders like diseased valves or diseased myocardial tissue due to heart attack, and could also be caused by various dysrhythmias, and also chronic stress can also lead to heart failure. Now, typically, left heart failure is more common. About 3/4 of the cases are left heart failure, and the remaining quarter are right heart failure. Now, right heart failure is typically a result of failure of the left side of the heart. So typically that is where heart failure stems from. If we think about what each side of the heart does, it kind of helps us to understand a little bit better what situations can occur. So remember, the left side of the heart is responsible for getting blood to the rest of the body. So if the left side of the heart is failing, then systemic pressure is going to be lowered and the body's tissues are going to retain fluids. So we're going to see congestion and swelling and edema with that. As that left side of the heart begins to fail, that can cause issues with the right side of the heart. And remember, it's responsible for getting blood to the lungs and back to the heart so that it can go to the rest of the body. So if the left side of the heart isn't functioning well, then it's not pumping out the blood adequately that's coming back from the lungs. So this is going to cause a backup or a congestion in the pulmonary circulation system. So now we have kind of like, it's, 5 p.m. on I-17, and we have all of this, this domino effect that is causing a delay. And that essentially is what happens when we have the left side of the heart failing is going to cause the domino effect into the right side of the heart. This can put a patient at risk of death, and diseased hearts can be replaced by living donor hearts or by artificial hearts. Although we have been doing these for years, physicians and experts are still working to perfect it. However, I did hear that they are bioengineering organs in space as we speak. So there is new hope on the horizon. Here is a picture of a heart that sustained congestive heart failure. You can see that the right ventricle is very enlarged and the wall is very thinned, right, because of this congestive heart failure occurring in the left side is causing a backup in the system on the right side of the heart. This concludes our review of Chapter 14 of The Heart. I hope you found it helpful. I hope that I was able to clarify some of the muddy concepts in this chapter. Thanks for listening.